Hello, my name is Tom Stinchcombe. I'm a medical oncologist who specializes in thoracic oncology. I work at Duke Cancer Institute in Durham, North Carolina. And thank you for having me today. So MET exon skipping alterations represent 2 to 3% of all the molecular alterations that we see. And importantly, this alteration is actually found in patients with squamous histology. Most of our other actionable alterations are predominantly detected in patients with adenocarcinoma. And so this, I think, encourages us to test the non-squamous as well as the squamous patients because they can have this alteration. Also, the demographics are slightly different. These patients tend to be older with a median age of around 70 in some of the trials. Two drugs available are one drug called cabozantinib, and this was tested in patients who had treatment naive as well as patients who had been previously treated. And the response rate was higher in the treatment naive, response rate close to 70%. The duration of response was about 12 months. The most common side effects of this specific drug was peripheral edema, some nausea, as well as some vomiting, and it can cause an increased creatinine. That was the first drug approved, but very quickly afterwards, a second drug that also targets this MET exon 14, and that's a drug called tepotinib. This had a first-line response rate of around 45%, and a second-line response rate of 45%. And the adverse events observed, it was very similar to the previous drug, cabozantinib, in terms of the rate of peripheral edema, nausea, and some lower albumin. This study also included patients with liquid and tumor biopsies, and the response rate was roughly similar whether you had a liquid or a tumor biopsy. I think the take-home points with this is, one, you got to make sure you test for this mutation, and you also have to test squamous patients for this mutation, and that the demographics are slightly different. I think the big thing with these drugs is both of them target the MET pathway, so that's why you get the peripheral edema, and that can be problematic if the patients develop the edema, and often you have to be very vigilant when they're developing this and dose reduce. I've tried Lasix as well as compression stockings, which have been modestly or marginally effective, so I think this is a case with edema that counsel your patient and really be aware that if it starts to develop, that a dose reduction or holding and dose reduction are probably the best method of addressing the edema. And the reason is that the edema can be inconvenient for patients and affect their quality of life. So it's not just a minor toxicity when you think of the impact on the patients.